Why?
You know, the other 11 in the next couple of weeks. So, and the other
So
thing
you're
is,
about half.
Yes.
which is very confusing.
That's a little less than a quarter of what the total.
And then he did actually move to table before we passed it, and then
Last
not.
number I had, 47 million negative in five. No, this was projected to be under the last number, so you're 11, you're gonna get back, and 11 you're not gonna get back. You're 11 of the 47. This is just the difference between what the last is supposed to be and what the last is going to be. Yeah, it depends on all that happy stuff.
Because Nathan will tell you.
Right, but your amount under the lapse that you're repaying is less.
So, yeah.
Considering your budget, you're doing well then compared to other people. But then you've got your $80 million, and you've got your net ditch, and you've got your.
Call to order the meeting of the Health and Human Services Oversight Committee for Friday, March 28th. And for the record, so far the Boston Red Sox are undefeated this season. Would the clerk please call the roll?
Yes, well, no, I wouldn't, because I don't have the list, but I will note that Senators Rosenwald and Gray are here, that Representatives Woods, Pearson, McDonald, Weber, and LaMontagne are here. I'm sorry for doing it backwards, but that's.
That sounds good. Next item, draft minutes approval, February 21. You should have received that in the email, and you should have a copy before you. Remember, this is not updates. This is simply, do the minutes reflect what actually mostly was said and done?
So moved.
Any further discussion? Hearing none, vote on approval of the the minutes. I missed lunch already. Please say aye.
Aye.
Opposed? Thank you. DHHS Commissioners Update. Commissioner Lori Weaver. And Tricia Tilley.
We make it
And-
harder with the bigger chairs.
I don't think she can fit with me on it.
And I can now call you my fellow as well, right?
Yes,
Yes.
for today anyways. So I have Trish Tilley also joining me to give help. I figured the update you would most be interested in is what was going on with the sudden termination of the federal funding. So I thought we'd talk a little bit about that for the update. Obviously we've been busy working with Division 3 on our House budget, and I'll have to skedaddle after this to go down the hall to that session. But focusing on the sudden termination, I just want to set the stage and just give you an idea. Most of our staff had left for the day when at 5:38 p.m. on Monday, in comes an email that basically says you no longer have this funding effective immediately. So you can imagine the surprise from our staff on Tuesday morning when they opened up that email. So it did create quite a bit of panic. You'll hear the number 80 million, and we'll talk about that in a minute. But I just want to set the stage that we all know that when COVID happened, there was a lot of money that was for different purposes. And so when we think about this being labeled as COVID money, it was recognizing the impact that some of COVID had on our community. So when we think about behavioral health, when we think about obviously we automatically think about public health, I think first with the COVID, but we knew that it was far reaching and the impacts were in our community. So there was great flexibility from the federal government to be able to use this money as needed to be able to address those issues. So those issues could be direct services, they could be IT infrastructure to help with the services, they could be people, it's a myriad of things. We had for that money until September of 2026. So what the department did was plan its 26-27 budget, knowing that we had that money until September and then to off-ramp at that time for all of those services. So we had a plan. So we were not sitting on money unused. We were using all the money appropriately and with all the appropriate authorities to do so. So when that money ended, that meant I now have a 15-month gap to try to find, if I can, where I'm going to fund to continue that work. The bulk of the 80 million is in our public health, so about 75 million of that, and 5 million was in our behavioral health. So when we think about like our SAMHSA grants, those were not impacting services and they were not impacting directly positions for that 5 million. The position impact internally for HHS, we had 20 staff that, as you can imagine, were pretty distraught on Tuesday morning, realizing they no longer had funding for their position. We have worked diligently with our partners in DOP to be able to look at making sure that we don't lose folks if we don't need to lose folks. And we have been successful internally with being able to maintain our 20 folks. The downside is that the department also had a contract for some of our lab staff, and that was 20 staff that had to leave that day on Tuesday. So that was hard, as you can imagine, for some staff to see their colleagues, even though they were contractors, they're folks that have been around for a while. So when we think about the direct FTE impact, it was on the department and also in contracts. But if you take the 80 million total of the public health and the SAMHSA contract grants is what these were, there was about 61 approved contracts. So out of that 61, I think 47 of them were funded primarily with this grant. The remainder were funded with some parts of that grant. So we have been in analysis over the last several days of all of those grants. We've had to send notifications to all of the contractors regarding the funding, the services, which is obviously time consuming and very difficult. And then at the same time, assessing the impact of not having any of that anymore. And we're still doing that work today. A lot of the money in the public health, and Trish can speak a little too as we go through this handout here, but data is important in the work that we do, and a lot of this money was allocated to some data infrastructure, data systems work that we otherwise wouldn't have had. So we have to find a way to continue to fund that. But again, it wasn't, when people hear it's 80 million and they clawed it back, for the record, it's 80 million that was encumbered, approved, authorized, going through all of the machinations of having it work, and now we're having to revisit all of that. So some of the work will have to stop. I mean, that's the bottom line. And then some of the work, we're looking to see if there's other federal funding that we can use that would not be labeled COVID money. This was labeled COVID pandemic money from a federal perspective in their grant. We would be looking at other federal funds to supplement that. So Trish has put together a nice handout here to be able to walk you through a little bit more detail than I've provided, but I just want to set that high level overview of what's happened, and we're still assessing the impact.
Thank you, Commissioner. I think you did a great job of walking us through most of this, but I can highlight just a couple of extra things. So as you see, as you go through here, it was a number of grants. They were mostly, as noted, for epidemiology and laboratory capacity. This is really the nuts and bolts of public health. This is the part that you typically don't see very much, but it's what enables us to do the work. It is the data systems. It is the laboratorians. It's all the folks that aren't out front, but are making sure that we can do disease detection. It includes also a grant called CDC Health Disparities. There was a lot of conversation about the CDC Health Disparities grant a long time ago. For us, this right now, that was simply funding community health workers out in the community. That was, and so there's a direct impact out in our communities to our federally qualified health centers, our family resource centers, and our regional public health networks. There were upwards of over 30 community health centers out in every community that were paid for with this grant that we no longer have direct funding for. I will note, though, however, with our community health workers, and actually, quite frankly, for all of these grants, we knew the funds were determined to end in 26. So as good budgeters, you know, we sit down with and we think about how to use that money till the last minute and then what happens next. And so what this did was sort of lift up 15 months and we had a fast forward from there. For example, with community health workers, there's been a lot of conversation about how they can bill Medicaid. And so we've been working on that process for developing those linkages. We were set to have that finished by the time these funds ended, but they've ended early. So we're going to have to expedite some of that work to understand how we can have a reasonable billing mechanism so that these sorts of positions don't have to be grant funded. Similarly, with a number of the laboratory grants and the data system grants, we have some funds that we anticipate next year that we were going to continue some of that work. Also, some of that work should have been just done. Again, a lot of the data work, a lot of the data infrastructure, was supposed to be stood up. We have a number of systems that we're not sure that we're either going to have to end, scrap, put on hold, which quite frankly is quite costly at the end of the day to have done work and then because it's not finished to put it on ice for a couple of years until we can find more money. It's going to cost more money eventually when we have to start back up the work. So that's disappointing in that area. Other activities, again, that you'll see on the bottom of this sheet, so community health workers, laboratory function. Interestingly, we have a contract with an organization called On-Site Medical Services that again, provides the medical direction and medical support when we go out for an outbreak or have to do some vaccinations. This group really works for things like tuberculosis. I think we've heard in the news over time that we've had several outbreaks of tuberculosis or cases of tuberculosis, and we're going to have to find another way to be able to do some of that work out in the community. On the behavioral health side, we're looking at CTI, critical time intervention, which is that support for individuals transitioning out of behavioral health inpatient facilities. Again, this was some supportive money, not as much the direct services. As the commissioner noted, we have to understand a little bit more how our vendors were paying for a part of a person, a whole of a person. That's taking some time over the course of the week. Our priority was just simply this week telling them, stop work. In addition to stop work, you need to bill us within 10 days so we can pay you for whatever we haven't paid you so far. And that's disruptive to our community partners. We typically don't give our community partners 10 days to bill us. So they're going to have to do that work on that side. There was some other training and workforce support for behavioral health, again, for our first responders and for New Hampshire Rapid Response. As the commissioner noted, we had 20 staff members in DHHS. We have a plan for almost everyone. We will have a plan for everyone. That includes some voluntary resignations in that as well. And moving around of vacant positions. I'll note that again, since the pandemic, we've had many staff that were paid with temporary funds, and we have been consistently rolling people off through attrition, through planned work. Those positions have become vacant. These were the last 20 that were using any of these COVID era funds. And again, we had a plan for off-ramping many of those positions with funding that we knew were going to be available in the upcoming years. So now we have a 15-month gap to try and figure out in our budgeting. And then finally on the list, I have a list here of the community partners, our vendors who were impacted by the sudden cuts. And we're happy to answer any questions.
I am sure you have contacted our congressional delegation, as many other states have, and we do not see much hope
No, and I will just suggest, and the governor has been incredibly helpful and supportive to us through this process as the federal delegation. They reached out to us. We didn't have time to call them. They were texting me right away that night, asking questions. So they've been working with us, trying to understand the impact, both here in New Hampshire at the governor's office, as well as with our delegation.
Any questions? Senator Rosenwald.
Thank you. The 20 staff members or up to 20 staff members that you're moving to other presumably vacant but funded positions, is that going to affect your labs?
I'll let the commissioner answer, and then I'll follow. Oh, you want?
No, I can answer. I just, so the 20 positions, it's not like they're all the same in terms of how we work them. So for some of them, they only needed a small tweak in terms of the federal funding being changed out. So that would potentially still stay in that position. I think we're down to about 5 out of the 20 that would be reassigned in lieu of what we call reassigned in lieu of layoff. And then it would be a swapping out. So we're trying not to impact where we're at for laps. We're just trying to make that even Stevens.
I'll use just another example. We had a bureau chief for our emergency preparedness. We had been using this money because this money was federal and good and easy, and we knew it was going to end. But we always had a plan for then cost allocating her across her other federal grants. So now we just cost allocate her across those other grants. So we had to do a lot of those sorts of financial moving around. So many of the 20 are staying in their exact position. They just have a different funding source. And then there are a smaller number where we might have to move into different roles.
Follow up?
Yes, thank you. So could you please put into, dumb it down, what the impact on the public health labs will be?
So I appreciate that.
What
So
won't they
what
do?
we've seen is, a number of these staff and a number of the temporary staff in particular worked in our water lab. And so our water lab has generally not been, is generally funded by general funds. And this was an opportunity to use federal funds to augment that work as the water lab work has increased, especially with things like PFAS. So the demand on the water lab has increased over time. I know Senator Gray has done us a great favor and helped sponsor a water lab bill for us to have a little bit more sustainability for things like the equipment needed in the water lab, reworking the way we do our administrative rules so that we can capture some of the funds that we get for testing to help maintain that. So the water lab is a place that we are now short-staffed is probably the easiest way to say it, right as we're getting into the summer period when we're going to need to test water bodies, where we not only test private water systems when people come in and ask us to test their water, but also places where people swim, those other activities. So that's an example. We have, it will impact some of our ability to buy what's called reagents and the supplies needed to do a lot of our testing in virology, in any of the infectious disease. There's just a reduction there, and we're going to have to figure out where else we can find those funds. Those are just 2 examples.
Representative Weber.
Thank you. Thank you. I'm working at trying to figure out how to chew gum and walk down the street at the same time. But following up on Senator Rosenwald's first question, I wanted to get a little more clarity about, so you got 15 that have either retired or capped with other funds, and you got the 5 that are either laid off or swapped out. And I'm wondering whether it is laid off or whether it's swapped out. Are these people who simply don't have a job today and might have one next week or next month? Or are these people who had a job doing X last week and are now going to be doing Y next week? I'm just wondering what kind of gap is there for the actual people.
Sure. So I'll speak to no one's being laid off.
Okay.
Everyone has a job today. like we said, we've gotten creative with our cost allocation of funding on the bulk of the positions. And then we would reassign potentially favorably within public health, right? So if I have a vacant unfunded, I may be swapping out positions to be able to make it work on the budget side of it, but there's still a need in the department. So we're able to, with 5, it's not like 500, right, or 50 even.
Right.
It's manageable.
Right, gotcha. And I'll just add to that. I mean, I think because this was in public health, these are very specific roles. It's not like, 20 caseworkers that can move around that all do the same job. There are folks that are virologists, folks that are a public health nurse, but we've absolutely worked very hard to make sure that everyone has a landing spot. For example, someone moving from the microbiology lab to our wastewater testing where there's some federal funds over there. So we're able to do some of that movement.
Thank you.
Senator Gray.
Not really a question, a couple of statements. The commissioner and I did talk about lapse right before this meeting, and my concern, because right now the state of New Hampshire is going to look at completing the year in a deficit condition, and that's part of what I'll need to help address as we get closer to the end of that year, is how we do that. So lapse is a big part of that, and if this increases the gap between what the lapse was expected to be and what actually comes in, that will affect that. And just give the commissioner a heads up is that my assistant or aide is already starting to schedule the testimony for the Senate side of this, and you've only got a couple of weeks to figure this all out and get the numbers back to me. So
This is where I say I love my job. Yes, no, we're prepared for that. I think I just want to be clear, losing the 80 million doesn't mean we're going to be able to refund all of the 80 million. Things are just not going to happen, right? So we're getting as creative as we can with this gap of what we can backfill, but there's just some things that aren't going to continue or be put on hold.
Absolutely. And, I think just, I don't know if it makes you feel any better. Certainly public health is 85% funded with federal funds as it is right now. So that is the flexibility that we're digging into more than a notion of relying on general funds to backfill any of this. It's really a matter of what do we have on our plate that we can move around.
Chair recognizes Representative Dr. Wood.
Thank you, Mr. Chair. This is for my own edification. I just make sure that I understand from 30,000 feet, the money, a lot of moving things on the ground, but if I understand it correctly, the money was going to disappear in 15 months anyway. This was just sort of premature, so planning could not occur. Is that, am I being too simplistic, or is that correct?
That is correct.
Okay, good.
We had 15 more months to spend the money. We had budgeted out for 15 months. It wasn't that we had not planned for anything. It wasn't like we didn't think to build a building. These were funds that were budgeted. We had a contract to do this work. The work was approved, and the federal government said, stop.
Yeah, I just want to make sure I understood.
Anything else, Commissioner Forrest?
Oh, I think that's enough for now. Thank you.
Thank you for this.
Maternal mortality report, Dr. Carolyn Nyamasegi and Ms. Erica Tenney. You can pull another chair. We got to get wider, longer tables. This just isn't fair.
we do have plenty of seats with microphones at the other side.
Right. I mean, you could always use the ends of the table.
Yeah.
Oh, no, I'm not pretending on this.
Okay.
Thank you.
We do reserve for you the ability to sit at the end of the table at your pleasure. Okay. Rule number 1. Turn the microphone on.
There we go. How's that?
You're good.
Better? Fabulous. Good afternoon. Hi, my name is Allison Power. I'm filling in for Erica Tenney today, who's home with sick kiddos. I'm the perinatal nurse consultant at the maternal and child health section in the Bureau of Family Health and Nutrition at the Division of Public Health.
To the microphone, please.
How's that?
Yeah, just
Better?
Pull it very gently.
There we
closer
go. I
to
don't
you.
want to unplug it.
I know, very gently.
So I'm in the MCH section at DPHS within HHS. Thanks for having us here today to share with you important information about maternal mortality in our state. The function of the Maternal Mortality Review Committee, the MMRC, is to conduct comprehensive, multidisciplinary reviews of maternal deaths, to identify factors that contributed to those deaths, and to make actionable recommendations for clinical and non-clinical interventions that will improve outcomes for pregnant and postpartum women in New Hampshire. The MMRC has completed a 5-year grant from the CDC that was awarded between 2019 and 2024 and has been recently awarded another 5 years of funding. This grant has enhanced the MMRC's ability to review New Hampshire maternal death cases and has improved our ability to create actionable recommendations to reduce maternal deaths in New Hampshire.
Hello, my name is Caroline Nyamasege. I'm a maternal and child health epidemiologist, also within the maternal and child health section, Bureau of Family Health and Nutrition, Division of Public Health Services. So I'm going to give an overview of maternal deaths that occurred in the past 1 year, that is 2023, and a 5-year aggregate. So in the calendar year 2023, we had 5 pregnancy-associated deaths. So pregnancy-associated is a term used to define all deaths regardless of the cause. And 3 died from substance use overdose, 2 from cardiovascular, and 1 homicide case. Pregnancy-related deaths refers to death while pregnant or up to 1 year from the end of pregnancy from any cause related to or aggravated by pregnancy or its management. So the proportion of deaths related to substance use disorder decreased from 62.5 in 2022 to 40% in 2023. I know these percentages may look like it's a high proportion, but it's because our numbers are very small.
Sorry, I'm having trouble keeping up because I'm trying to do 2 things. Could you tell me where in the report you're looking at? Are you looking at some figures?
Yes, so from page 5 onwards.
Okay, page 5.
Yeah.
Thank you.
And so we just presented a small version of the report. The finalized version will be sent online by John. Yeah, so we've seen a decrease in overdose deaths from 2022 to 2023, and that's because we had fewer cases and probably because of the interventions that have been happening. So due to small numbers, like we only had 5 cases in 2023, we aggregate 5-year data to understand data trends and determine various maternal characteristics associated with these deaths. So most pregnancy-related deaths were non-Hispanic white. Most happened among women who are aged 25 to 34 years old, and about half had a high school diploma or less. So 50% of pregnancy-related deaths in New Hampshire from 2019 to 2023 were due to drug overdose. And 62.3% of the deaths occurred postpartum, while majority, which is 67% of those overdose pregnancy-related deaths occurred between 43 to 1 year postpartum. 73% of those who died from overdose were Medicaid recipients. Half of the overdose deaths had a documentation that finances and transportation were barriers to healthcare access. And almost half of the pregnancy-related maternal deaths occurred at the decedent's residence, and this is because they were mainly overdose deaths. The Maternal Mortality Review Committee determined that mental health condition was the primary underlying cause in 58% of pregnancy-related deaths. And substance use, mental health condition, involvement of deceased wife, intimate partner violence, socioeconomic struggles such as unemployment, lack of transportation, and lack of care coordination were some of the factors identified to be contributing to maternal deaths in New Hampshire. New Hampshire Maternal Mortality Review Committee determined that 79 of the 5-year aggregate pregnancy-related deaths were preventable. We want to acknowledge Medicaid expansion, which you all approved. Thank you very much. So expanding Medicaid through 1 year postpartum, which we hope will increase behavioral health service utilization, since most overdose deaths occurred postpartum. That's 3 months to 1 year. This has been an early recommendation of Maternal Mortality Review Committee and one that has come up several times. That's the Medicaid expansion. So in the report that you'll be receiving, we also included pregnancy-associated deaths. So pregnancy-associated are just all deaths, regardless whether they were related to the pregnancy or its management. So the report that you'll be receiving, which is not in the report that you have right now, will have an appendices section that has all the pregnancy-associated deaths that occurred in New Hampshire. Thank you.
I can talk a little bit more about the recommendations that the MMRC develops. So as Caroline described, mental health and substance use disorder continue to be the main drivers of maternal deaths in New Hampshire, but significant gains have been made to intervene in this trend. In 2023, key recommendations emerged around partnering with the Department of Corrections to provide clinical education on the medical management of pregnant and postpartum women in the corrections system. And now a representative from the Department of Corrections will be sitting on the MMRC moving forward to provide subject matter expertise. The New Hampshire MMRC member organizations are key partners in implementing the recommendations that are based on the data to reduce maternal mortality. The Northern New England Perinatal Quality Improvement Network, based at Dartmouth Health, continues work following up on past recommendations. The team has been disseminating clinical education materials at urgent care centers and community health centers on the urgent maternal health warning signs during the postpartum period, and is building 11 regional coalitions to improve perinatal health across New Hampshire. And they're continuing ongoing clinical education and monthly webinars and quarterly clinical conferences and skill sessions on peripartum cardiomyopathy, cardiovascular emergencies, amniotic fluid embolisms, and psychiatric emergencies. Thank you so much for the opportunity to present on the latest efforts to eliminate maternal mortality in New Hampshire.
Do we have any questions? Representative McDonald.
Thank you, Mr. Chairman. I think you may have addressed this, but if I could just follow up or clarify. Looking at the executive summary and leafing through the report, and it's great, thank you. It talks about the mortality rate going down significantly in recent years. It's 18.6 now, and before that it was 22.3 and as high as 32.9 in 2021. And again, could you clarify, or maybe you already have, and I apologize if I missed it, but could you explain why you think that's been going down, which is great, and hopefully that trend continues?
Yeah, so the data in the executive summary is so I started with the overall US rates. In 2021, we saw the highest rates, and that's because of the pandemic. The highest rate was reported among the Black or African American, but generally it was the year that we had the highest rates of maternal mortality because of the pandemic. But I think the decrease could be because of that high increase in 1 year, and then now it's going down because the pandemic has kind of ended. For New Hampshire, we cannot really say that the decrease is steady because some years we have 5 maternal deaths, some years we have 8. In 2022 report, we had to combine 2 years of data because we had 5 cases in 2021 and 6 cases in 2022. 6 cases in 2021. In 2022, we had 8 cases, and now 2023, we had 5 cases. So it's not really like a steady going down. We cannot tell, but from whatever we are seeing in the current data in 2024, we also had few cases which we'll be reporting next year. So we believe the money that has been put by the federal government, this CDC funding, is helping states to work on some of the interventions, like my colleague mentioned the recommendations. So we believe that this is attributable to the recommendations that they have given and whatever interventions that we are working on to reduce the number of deaths in our state.
Okay, can I have a follow-up? Are we at, and this is going back a way, so I don't know if you know offhand, are we at pre-pandemic levels for the mortality rate now, or?
No, no, we have improved significantly.
Oh, so we're even better than that,
Yes, we are much better than the pandemic levels.
than pre-pandemic levels too?
Pre-pandemic, we are slightly better than the pre-pandemic levels when I look at the trend, the overall state trend. But for New Hampshire, I can say we haven't really had like a steady decrease. It's been up and down. But right now, for the 2024 cases, we have seen very few, like around 5 deaths. So it looks like we are improving in terms of maternal deaths in the state.
Thank you.
You're welcome.
Senator Rosenwald.
Thank you, Mr. Chairman. Thank you for taking my question. So I think it's great that we have so few maternal deaths, but we've been doing this work for a long time, and you point out that 79% of these deaths are preventable. And I have this tug of war within myself, whether it's the department's responsibility to drive them down, or if it's the healthcare provider's responsibility. And the healthcare provider keeps coming out on top for me because that's the person who has the relationship with the patient. So I wish you could just talk a little bit about why you think it's the department's responsibility and not the clinicians.
The way thank you for your question. The way that MMRC is designed is that we have a very intentional makeup of clinical and non-clinical contributors to the MMRC. And all of the members of the MMRC represent specific clinical specialties in maternal and child health throughout the state. So there's maternal fetal medicine, there's reproductive psychiatry, there's midwives, there's directors of labor and delivery units. So especially in a state like New Hampshire, where a woman can bounce around quite a bit, when the MMRC actually all gets in the same room, that's really the place where those clinical conversations are going to be had. Because the other thing to consider is that when we're looking at a maternal death, we're looking up to a year postpartum, and that woman may not have been seen by her obstetric provider at all postpartum. And so those providers have literally no information on the woman's care, the trajectory that led to her death. So I would say that the department is really the singular place to gather all those clinical folks together. And then they're the ones that make the recommendations, and those recommendations are then disseminated out to all the birthing hospitals in New Hampshire through other projects that we collaborate on. Anything else?
Yes, Paul.
I want to add up on that. I think when we say that the MMRC determines 79% of the pregnancy-related deaths were preventable. First of all, we are not trying to lay blame on anyone, not on the department, not on the clinician. It's just that we are trying to understand the circumstances that led to death, and then MMRC determines if we are able to prevent this death. And once they decide that it's preventable, the recommendations that are made, they are not made like the department is supposed to do something about it, but we make recommendations targeting different agencies. We look at, is this recommendation for the community? Is this recommendation for the clinician? Is it for even the families that were supporting this decedent? So the recommendations are the preventability is just a statement that we make, and we are not saying that the department is responsible for reducing like this number of deaths, right? I feel like it's the responsibility of everyone, including clinicians, including the family members, and including the community where this person lived.
Follow up.
Thank you. So you also on page 10 point to the importance of mental health conditions or substance use disorder issues, which I think generally aren't treated by OBGYNs. But most of these women had treatment. So I guess I don't understand why it's not the clinicians in various specialties of medicine, why it's not their responsibility to care for their patients.
So when we look at the contributing factors, I think when someone dies, so many things come to play. One being finances, others being even themselves not wanting to take the medicine that they have been given. We have cases where the decedent did not take medicine. The challenge we have in New Hampshire is inadequate mental health care services. We've had cases where the individual could not get an inpatient admission because it was full. So I don't know whether that is the clinician's responsibility to have prevented this, or it's the system's responsibility because we have fewer mental health services. So they may have Medicaid, like Medicaid was the majority of the deaths. They may have Medicaid funding, so they have the insurance, but they have a wait list of seeing a mental health care provider, and in the process with like overdose deaths, they just happen. So I really don't know how best to answer your question, but I feel like it's the responsibility of everyone to really prevent these deaths. Everyone who is involved in the healthcare system. I don't know if you have any.
Representative Woods.
Thank you, Mr. Chair. And thank you for taking my question. The senator just alluded to some issues that might be addressed, and you answered them. And my question is, are there other examples? You mentioned sometimes can't get an admission, a proper timely admission, or education in terms of taking a medication. Have you identified other very specific things? I mean, the overview is good, but are there other things that you can identify for us that would be very specific if we needed more practitioners? I mean, if it is partly falling on the practitioners, it may be availability versus accessibility. It's just that it's available but not accessible because of diminished clinicians. Can you identify some of those that are very specific that can be addressed?
Back on? Okay. Turned it on. If you turn to page 13, you'll see recommendations that the MMRC develops. So to answer your question directly, when an issue comes up about mental health, for example, that we think contributed to the death, a very specific recommendation with a who is doing what by when recommendation will come out of the MMRC. For example, in the past, we've seen many recommendations come out around mental health. And so the idea of peer recovery, support programs have specifically related to the perinatal period, pregnancy and postpartum, were determined to be a feasible, actionable recommendation for the MMRC to develop. So now a peer recovery group is operating out of Dartmouth, run by NEPQUIN, by the Perinatal Quality Collaborative. So the point of the MMRC is not to paint broad swaths of changes that may not be feasible. The point is to develop actionable recommendations, whether it be related to mental health or substance use disorder. So, for example, there were cases related to substance misuse where we needed to do some more clinical education on how to manage pain during labor for a patient who has an existing substance use disorder. And so Dartmouth, over the course of years, ended up developing new clinical guidelines implemented by the birthing hospitals on how to actually administer pain medication and, dosages and timing and stuff of powerful opioid medications during labor for a patient that already has SUD. So I hope that answers your question related to the actionable recommendations.
So maybe just to add, I said this report was not like whatever we gave was not complete, but we did list. So MMRC, every time we have a case presented, the committee looks at all the contributing factors that might have led to that case. And we pulled all these contributing factors for these 2019 to 2023 cases and did do a kind of qualitative analysis to present those contributing factors, and they have been listed in page 11, which will be handed to you later on in a soft copy. But we have highlighted specific things that contributed to these deaths, and they are organized in terms of substance use disorder, mental health, clinical workflows. So, for example, under clinical workflows, the MMRC determined that need for clinical guidelines and training on labor and postpartum operative pain management for patients with SUD. So probably that case was something that was involving the pain management. So we have listed, it's a list of so many contributing factors. I think once you look at them, you'll understand, and we draw our recommendations based on these contributing factors.
Any further questions from anyone? Seeing none, thank you so much for your report.
Thank you.
Appreciate. Now the chair recognizes Mark Clemens, Josephine Porter, and Courtney Keene for Child Fatality Review Committee's annual report.
Remember this table over here, you can use that too.
That's all right. We'll squeeze it. Yeah, a little bit.
We should telephone book or something. Hold my elbows up.
Good afternoon. Can you all hear me? Loud and clear? I'm Courtney Keene. I'm the Bureau Chief for Family Health and Nutrition. I'm joined with the co-chairs of the Child Fatality Review Committee, and I'll let them introduce themselves, and then I'll do a little introduction.
My name is Mark Clement, one of the co-chairs.
Hi, and I'm Joe Porter.
Everybody needs to be closer to
And I'm Joe Porter, also a co-chair.
Oh, I'm Mark Clement again.
All right. So the New Hampshire Child Fatality Review Committee's commitment is to better understand the patterns and circumstances of a child death in our state to prevent further tragedy. The Child Fatality Review Committee recognizes that each child fatality impacts a community and a family who have suffered the loss of a child. The work that is done is to conduct a comprehensive review to lead the recommendations to prevent further deaths such as ones represented in this report. And I'm going to turn it over to Mark for the history and goals.
Okay. Thank you again. My name is Mark Clement. Thank you for this opportunity to talk with you about the work of the New Hampshire Child Fatality Review Committee. I'm one of the co-chairs, as you know, along with Joe Porter. I'm going to talk briefly about the history of the committee and how the committee functions as we review the deaths of children who die of other than natural causes. Now, the New Hampshire Child Fatality Review Committee was inaugurated by an executive order of Governor Jed Gregg in 1991. The committee was reconstructed in 1996 by a subsequent executive order of Governor Merrill, which placed the committee under the auspices of the Department of Justice, where it remained until 2019 legislation, which placed the committee under the Department of Health and Human Services. The committee published and sent to Governor Shaheen its first annual report in October 1998. And this is an actual copy of the report. You can see it's probably a little bit different than the one that you have in front of you. So how does the committee do its work? Well, the legislation provides 5 objectives for our review committee work.
First, to describe the trends and patterns of child deaths in New Hampshire, to identify the prevalence of risk and risk factors among the population of deceased children, to evaluate the services and system responses and offer recommendations for improvement of these services, to improve the sources of data collection, and to enable state agencies, law enforcement, healthcare providers, and community-based organizations to more effectively prevent and investigate child fatalities. Now, we have a committee of about 29 highly placed and highly qualified professionals who represent virtually every New Hampshire public and private agency that's working with and for children. To give you a sense of the scope of our members, we have, for example, the district court judge, the head of the Granite State Children's Alliance, the state child advocate, state police, members of the fire marshal's office, the head of the Injury Prevention Center at Dartmouth, a representative from the Attorney General's office, the head of DCYF, the director of the CASA program, members of the medical community, and the chief medical examiner, to name just a few. The full list, of course, is in your annual report. The committee meets every other month to review child fatalities and to generate recommendations. The executive committee meets the other months to select the cases to review and to conduct the committee's business. Now, we rely on three general principles in conducting our reviews. First and foremost, one of the major responsibilities is confidentiality. Every member signs a confidentiality agreement that prohibits them from sharing any information discussed in the review. And any non-members who come to the meeting to share information about the death, for example, a police officer who investigated the death, is also required to sign a confidentiality agreement. Secondly, we are not an investigative body. We take information that is brought to the committee by individuals and agencies that have information to share about the death. And lastly, we do not review any deaths that are presently in litigation or have the possibility of future litigation. This is our guidance from the Attorney General. After all litigations and appeals have been completed, we'd have the opportunity to review that death. Now, we start each of our meetings in a public session where, after some introductions and initial business, we have a presentation regarding data and regulations that are related to the type of death we are reviewing. For example, at a meeting where we might be reviewing fire-related deaths, we had members of the Fire Marshal's office give a presentation on fire deaths in New Hampshire and fire safety regulations. The purpose of these presentations is to have everyone on the committee aware of the latest recommendations and data for that particular type of death. At that point, we go into non-public session, and any members of the public who are present are asked to leave the room. Information about the death is then presented by any individual or agency that has information. We typically start with information from law enforcement, then we go to the chief medical examiner, DCYF, EMS, medical information, behavioral health, and anyone else who has any other information from their agency. After we've reviewed all this information, we move on to the recommendations part of the meeting, and this is where I'll pass this on to my co-chair, Joe Porter.
Thank you, Mark. Is this okay? Audio? Okay. So as Mark said, I will happily walk through some of the recommendations from the latest annual report. I thought it might be helpful for you all to get a bit of an orientation to the report that's in front of you. So hopefully you all have this report, and I should give kudos to the department folks who actually put this together. Jess, amongst folks who's in the back of the room. But what we've tried to do in this report is provide at first a sense of who we are as a state in terms of how child fatalities are impacting the state. So we are in a very fortunate circumstance where we have few child fatalities in any given year. So what you see is data that reflects the most recent year, but we also see 5 and 10-year data points that combine enough data to be statistically reliable when you will then look at trends over time. So the first part of the report really indicates the kinds of fatalities that exist among New Hampshire's youth. And then around page 12, if you are interested in going there, you'll start to see where the recommendations come forward. I've been on this committee since the 2019 revamp of the legislation. Mark has been doing this much longer than I have. And we're fortunate, again, that our rates of death are very low in this state, and what we end up seeing are very similar causes of death year to year. So we end up looking at deaths that are similar in nature as we go through a couple of years worth of data. But one of the things that we do, in addition to choosing cases that are representative of the most common sorts of issues that arise, is sometimes we do have causes of death that seem to be reflecting more emerging trends. And we try to be cognizant of being as timely as possible as we're reviewing those sorts of things. And we can give examples if folks are interested. But essentially what you'll see starting on page 12 and then really on page 13 are some of the tangible items that we brought forward as recommendations around these deaths. As Mark mentioned, one of the most important things that we have to be reminded of is this is not an investigative committee. Our job is not to dig deep into details of an individual case, but to use those cases to come up with broad recommendations that we think might prevent future deaths. And what you'll see are things like increased awareness and messaging around the importance of seatbelt use. Because as we've looked through motor vehicle deaths in the past, a common theme has been that these deaths tend to occur among children who are not wearing their seatbelts. Driver safety messaging, I'm sure as you all can appreciate, the trends that we see in some of the motor vehicle deaths include distracted driving and distracted driving for causes that may be emerging. So as we know that there are cell phones in cars, we do see the potential of having those distractions be factors in some of these deaths. We want to call attention to the needs for services around things like mental health treatment, because as we look through suicide cases, it tends to be, again, a common theme that folks who have sought treatment and not necessarily been able to find it. And then resultant later, we see some of these cases that have resulted in suicide. And then suicide prevention, awareness, and trying to bring that forward. We had some really interesting and I think important tangible changes to things like how the suicide hotline gets published, even on student ID cards. Those sorts of very tangible recommendations are things that we talk about in these committees. And then around drowning, again, as another example, water safety as an important education area, and increased availability of free and reduced water safety devices like life jacket loaner stations was a big important area that we talked about that we brought forward as well. So those are the kinds of recommendations, again, that we bring forward in the annual report here and that we talk about in our committee. I just want to mention also that having the breadth of experience around the table is what sort of lets us figure out not only what the issues are, but where some of the solutions may lie. So for example, in that life jacket loaner station, we were able to better understand how Dartmouth Injury Prevention has those available and how we might be able to work with them to expand those to other parts of the state, just as an example. So those are this year's recommendations. Next year's recommendations obviously will reflect the cases that we talk about next year, and we look forward to the opportunity to bring it back to you again a year from now. And happy to answer questions.
I notice under the life jacket loaner station on page 15, two of the three are in Kingston, and since I represent Kingston, thank you. The third one is Derry. My son represents Derry. We would say that there are 398 other representatives who could jump in on this. Is there a plan for this to expand?
I think is this working? Yeah. We are always looking for opportunities for expansion. So, and the Dartmouth Injury Prevention Center would be really happy to work with folks to find additional outputs. Part of this is finding the right folks who are willing to keep maintenance on those stations. So obviously you can have a station, but if if the life jackets get outdated and there's not sort of ownership of that, but happy to try to find additional folks who would be willing to do that. And we have seen in the course of our time some consistency in where we've seen some of these deaths as far as, higher risk public waters. And so we're trying to work with the folks in those very specific stations.
Representative Lamontagne, and welcome to the committee.
Thank you. Yes, this is my first time in the Oversight Committee hearing. I am really so disturbed by the high numbers of suicide in children. And I'm wondering why you didn't break down the means of suicide and how you might be able to interpret more prevention recommendations on that.
Yeah, so I'm trying to, so page 9 has the methods of suicide. Yeah, so I'm pretty sure that one's there. So you'll see on page 9, figure 3 is the method. Yeah. So that was that part. I mean, I think a lot of what we tie back to is there are childhood traumas that seem to be addressed, that seem to be underlying factors for a lot of the suicides that we review, and then a need for improved mental health services for youth. Those tend to be, I would say, the themes that we've seen in the multiple suicide reviews that we've done. So you'll notice in this report, we also tie back to the mental health plan that the department created and trying to find ways to make the recommendations that are in the 10-year mental health plan realities. So again, from your point of, what are our recommendations? A lot of them do revolve around improving the mental health care system and the availability of services for kids.
Is it too soon to have some data that would be useful around the 900 emergency number?
Oh, the 988 number? I'm not a 988 expert. I do know that we had them come to the committee and talk to us in the education sessions that Mark mentioned, and they were able to run through some of their case numbers and how well the numbers seem to be used. And obviously we can't identify prevented suicides, but we were encouraged to see the uptake in that. And I'm not sure if they have information that folks in the department might know if they are able to show sort of improved usage after some of the campaigns that they've done. But that is another one of the areas that we've highly recommended, is to make those as widely known as possible.
Representative McDonald.
Thank you, Mr. Chairman. Just curious, and I don't know if you know the answer to this, in terms of the causes of suicide, to kind of follow up on Representative Lamontagne's concerns. Do we know what role bullying? We know that's a major problem. Do we know how prevalent or how significant that is in terms of impacting this cause, or this cause of death?
You want to talk about that, Mark, or you want me to? Okay. I would say again, it has been a theme that we've seen for sure in some of the cases that we've reviewed. We've seen situations in which some of the children, have pulled away from school. They've had notations either from family members or from the schools when we get school information about some of the challenges at school. So I can only say that for the few cases that we've reviewed, it is a common theme. I don't have quantifiable data on that, but it is a theme that we've seen in the recommendations that we've done.
So it's one of the most significant contributing factors to suicide, would you say? Is that a fair statement, or?
In the ones that we've reviewed, so again, we may only be reviewing 4 or 5, but the impact of challenges in the schools have come up in multiple cases.
Okay, could I have one final follow-up?
One follow.
And just to clarify, and I think I know the answer to this, but on page 9, talks about suffocation being the number one method of death, intentional deaths. Is that hanging, suffocation caused by hanging? Yeah, thank you.
Representative Woods.
Thank you, Mr. Chair. Focusing on the motor vehicle deaths and the issue of safety belt use or non-use always comes up. Are you able to collect through what method whether the safety belt was used or not in a particular motor vehicle accident? I'm not currently, but in the late 80s and 90s, I was much involved with the safety belt movement. And at that time, reporting the use was not something that was required. Is that changed, and can you currently get that data? There's been some very high-profile accidents in the state in the last couple of years where a tragic death occurred, but it was not identified whether the belt was used or not, which I thought would have been a good public education. Can you get that data?
Yeah, so I'm not sure how much systematic data is collected on that. For the cases that we review, we tend to have both the medical examiner and we have whatever safety, law enforcement professionals were involved in the response to and they typically will be able to know whether or not there was safety belt use in those cases. So that's collected at those levels, but I don't know if every single death has a record of that or if it's only when there's an investigation. That's the point I'm making.
Follow up?
But you don't know currently whether there's a requirement
I don't know.
in accident
Yeah.
reporting, whether it's a required entity to note.
Yeah, I'm not sure.
That would be so helpful for everyone. Representative Weber.
I'll just note from my last traffic accident, which was one where I wasn't in the car when it was run into, there was certainly a question in the report about whether I was wearing a seatbelt. And when I said no, because I wasn't in the car, they said, well, were you wearing a seatbelt before you got out of the car? And I said, yes. And they checked off, was wearing seatbelt at time of accident. I made them make a notation. So it certainly is on some reports at any rate, but that was a long time ago. My question was, you have qualified several times as to the cases that you reviewed. And so what I'm trying to understand is, are there cases of child abuse, child fatalities? I keep wanting to say abuse because that was the commission that Mr. Clements and I sat on. But are there child fatalities that you don't review? And how do you separate out reviewed from unreviewed?
Did you want to take that or you want me to?
The executive committee meets every other month to select the cases. We do not review every case of a child fatality. We simply don't have the time. And so we sit down with the medical examiner and we look at the cases that she has on file and select cases either that we think have some significance in terms of the ability to generate some recommendations that might be helpful in reducing the probability of those deaths occurring in the future. But the answer is no, we don't review every death. We make a selection of cases.
Follow up.
But am I correct in thinking that the actual number of deaths here is the number of deaths, not
yes.
the number of cases that you reviewed in
Exactly.
depth?
It's
So
the
you
number,
simply
yes.
have a subset that is reviewed in depth because of whatever factors you think are particularly relevant.
Correct. And those cases are the ones that generate the recommendations.
Yeah, okay, thank you very much. That's helpful.
Any other questions? Thank you so much for your presentation.
May I do one last thing, if it's okay?
Yes, you may.
On the record, which is I'd like to recognize my co-chair. This is his last time that you will see him, and you've seen him for many years at this session, and he has served on this committee since its inception. And he is going to retire as he should be allowed to, despite us not wanting that to happen. So I just wanted to be in the opportunity to be on public record to thank Mark for his time and service on the committee.
Thank you, Dr. Clements.
Yes, thank you. And I should say that every time I've been here, I've of course seen Representative Weber, so I think she's been around almost as long as I've been around, so.
Despite not always wearing a seatbelt.
Correct, yes.
Hardly ever when I'm not in the car.
And for the record, no member of this committee is presently wearing a seatbelt. Unbuckle and thank you for your presentation.
Thank you all very much.
Thank you.
Chair now recognizes Dr. Mary Beth Danulis, Dartmouth Health, Chair of the New Hampshire Rare Disease Advisory Council, to give the annual report.
Hello, and thank you, everyone. I'm Mary Beth DeNolvas. I am a pediatric geneticist at Dartmouth Health, and I'm the current chair of the Rare Disease Advisory Council. So I just wanted to start, and this is Courtney Keene, I'm sorry, and she's with the Department of Health and Human Services, as you just heard, and is my right-hand woman in this council. So I just wanted to give you a little bit of an overview of the Rare Disease Advisory Council, and really starting with rare diseases in general, because there's like over 10,000 of them, which really collectively affect about 25 to 30 million Americans. And so in 2018, around that time, the National Organization of Rare Disorders, they began an initiative in the United States so that their hope is that every state in the U.S. would develop this Rare Disease Advisory Council. And the premise being that these councils would advise the legislators, such as yourselves, as well as the Department of Health and Human Services and the community at large regarding rare diseases. So I'm proud to say that New Hampshire was the first Rare Disease Advisory Council in New England. And as you can see, it was signed into law in 2019. So I'm just kind of following along the outline that we gave you all. We have 12, oh, do you have?
Yeah.
I'm sorry, I thought I had all the names on the list, but we have Dr. Danulos, and give me the, yes, I should know, but I'm really bad with names.
You're fine.
Do you have this report here?
I have the report.
It's got some with names on it.
Sorry? Okay, so, yes. I have now found it, and yes, I have it. And is there one more copy of that floating around? Okay, thank you. Thank you. Just to be sure I've got everything. I got one, thank you. Yep. I'm sorry, I'm really bad at this job, so I...
The chair
everybody.
denies or nullifies your attempt to resign. Thank you. Nice to see you.
Go ahead. I'm all set.
Okay, great.
Thank you.
So our committee, we have 12 appointees who can be on the committee, and they make up patients with rare diseases, obviously their family members. We have healthcare professionals on the committee, 5 physicians actually, 2 state representatives and a senator. And I have to point out Cindy Rosenwald, Senator Cindy Rosenwald, who was part of our council for quite a long time.
Not on it anymore.
Yes, but for 2024 was yes. So thank you. And payers as well. And so, you know, the RSA is kind of outlined here on the page. So there's really 4 major points. And as I said, the largest one is to really, advise you all on rare disorders as well as the DHHS. And the other part is to collaborate with other rare disease advisory councils. So that's really important for us to do in order to share our experiences with others and glean information from them to help us better serve our populations. As well as outreach to the community and to bring awareness to rare diseases. I'm involved personally because as a geneticist, many of my patients have rare diseases. All right, so that's kind of where I fit into this. So our meetings are held every other month as well. And we have an agenda that goes forth, kind of listed here, things that we talk about. First and foremost are legislative updates. And one of our members, council members, just developed a really nice Excel spreadsheet where she put all the different House bills and Senate bills for us, for our council, that would pertain to rare diseases, so that we're able to link then to that bill and, testify if we feel like we would like to, write to our, to you all, giving you our thoughts on that. So that's really great. We also, looked to Senator Rosenwald, the senators, the representatives who are on the council to help us, understand the bills that are going through at that time that have to do with things that would be of benefit to the rare disease community. One big, I remember, and this wasn't in 2024, but just to give you an idea, is when Representative William Marsh put forth the telehealth bill, right? Yeah. And so that was really huge for our council because, individuals with rare disease, not only may they be immune compromised, and so, having the ability to do telehealth visits versus in person is really helpful that way, but also try to understand that rare diseases, they're so rare that, and in our rural state, our small rural state, is that we may not have the expert in that rare disease within our state. So in order to use, to glean the expertise from experts all over the country, telehealth was really great for that, for our patients. So I just wanted to point that out. We have other items here that we talk about on the agenda. I'll go over some of them a little bit later, actually, because I want to talk about sudden death in the young committee, which I'm very involved in, and as well as a lot of our outreach that we've done, because that is one of our tasks for community outreach. So as we go through, the way that Courtney so very nicely helped me with this report, if you see A in italics right there, these are some of the bills that, were important to us within the last year. And one in particular, especially for me, was House Bill 355, which was the one for newborn screening for cytomegalovirus. And that was just passed in July of 2024. So this is a condition, caused by a virus, but affects neonates, and very important to know if, in fact, the child has that disorder at birth. And I believe Dr. Rosenwald was, I'm sorry, Representative Rosenwald. Senator Rosenwald. Gosh.
Third of charm.
I know. I don't know why. I keep wanting to call you Dr. Rosenwald. So Senator Rosenwald was part of this SB 302. Relative to physician licensures, which was also important for us as well. Kind of moving along then onto B in italicized. This is like working with other advisory boards. In October of this past year, one other council member and myself, we went to the large, National Organization of Rare Disorders meeting for the RDACs, and I'll call it an RDAC, in Washington, D.C. And there were, 13 representatives there from, 13 different states. And we discussed a lot of topics that were really important. And it was great to hear what other states had, were doing and how they're set up. So not everybody is set up through the Department of Health and Human Services, as are we. And other RDECs have funding. We don't have any funding from the state, but so we're all volunteers. But there's a lot that can get done even with volunteers. So I had a little paragraph there about that. And then kind of going down to D, our community outreach, because that's really big and very important to us. A couple highlights here is that every year, I think almost just about every year, we've met with legislators at the Capitol, And we have a little booth there and talk about rare disease awareness. So trying to get that out, the awareness out to you all. We've had guest appearances on WMUR, newspaper articles, and a lot of these are surrounding what we call Rare Disease Awareness Day, which is typically February 28th, and it's all around the country. And so we get proclamations from the governors regarding this as Rare Disease Day, and we got one this year from Governor Ayotte. So it's really, it's near and dear to our hearts, but I think it's really important to get that awareness out there of people who are living with rare diseases. We illuminate bridges and buildings and things like that in the colors of Rare Disease Day. So,
What are your heraldic colors?
they're actually like pink, blue, red, but we kind of use like a purple-ish to bring it all together.
Wow.
Yeah. Okay. So moving on, one of the specific issues that I wanted to talk about, like I said, was the sudden death in the young committee. And it kind of, you've just heard about deaths in our state in children. And these are sudden and unexpected deaths in the state. So not something like an automobile accident, not wearing a seatbelt or a drowning really, but for individuals who we can't figure out what has caused the death. So when we think about that in our, in our committee, we think of extrinsic and intrinsic factors, right? So extrinsic factors being like the baby was co-sleeping with a mother or something like that, okay? Intrinsic factors would be those that certainly could be genetic, metabolic. And so I first started on this committee many years ago, and Courtney's now the director of the committee, and had noticed that we really did very little genetic testing in these children. And me being the geneticist I was a little bit taken aback, honestly, because my thought was, in many of these cases, they're like unresolved and undeclared, and we can't exactly figure out that about the children and how they died. So going to other meetings and listening to other states where they also had these sudden death in the young committees, many of them were instituting broad genetic testing for all of the children and all of the infants who died, regardless of what extrinsic factors were there. And so I brought that kind of through the Rare Disease Advisory Council because we had Courtney through DHHS, Representative Marsh, and we really talked a lot about this. And so we were able, I'm happy to say now, to get funding yearly for this, where we can do comprehensive, at least right now, seizure or epilepsy testing, as well as cardiac testing. So kids could have an arrhythmia, and the medical examiner could look at them and would have absolutely no idea that they died of an arrhythmia. Okay, you could have absolutely no idea that they died of some type of seizure encephalopathy. You can't tell on autopsy, you can't tell by any other testing that you do other than genetic testing. So I'm really excited about that, but that's also showing how we can collaborate. This is going to be funded through the CDC grant with help from the Department of Health and Human Services. So it's just, I think, a nice story to kind of say how we can pull all of this together if we collaborate. And this is really important not only for, the parents getting an actual diagnosis if it is genetic, in fact, but also testing other family members who may be at very high risk for things like arrhythmias, that type of thing. And also it brings closure to these families who honestly, felt that they absolutely did something wrong and their baby or their child died, when in effect it was really just your genetics. And so I think for all those reasons, I really gonna close with that, is that working collaboratively and through our Rare Disease Advisory Council, I think we can get a lot accomplished that is important for this community of rare disorders.
Chair would like to recognize a state representative, Dr. David Nagel, who was past president of your council. He was trying to hide in the second.
I didn't realize he was here. Yes.
We've actually never met face to face, so she didn't even, I don't think we even knew each other, right? We're just two beautiful faces on Zoom.
Why don't you pull up a chair and offer us a few thoughts?
Sure. I'm sorry.
Thank you. No,
If I would have known, I would have given you a big hug because she's a wonderful person.
Time has not run out on hugging.
It is not, definitely not. We're post-COVID. And Senator Rosenwald and I think we met on this committee, opioid abatement, on both. You were a picture on Zoom there too. So I've sat on this committee for a while. One of the interesting measures of success of a committee like this is when a disease no longer becomes part of this committee, because we actually have created recognition that it actually exists. And it's amazing how many diseases we don't know about, how common they are till we actually promote. Like Ehlers-Danlos, I will bet you anything will no longer be part of your work soon as a rare disease because we've created recognition for that. But I want to bring some questions for you that I think that we really need to talk about.
Can I ask my colleagues to share in the answers?
Sure.
Okay,
Yes.
good.
Definitely. So there's a couple issues that have come up recently. This group started in 2019. There was some nationwide thing that was going on shortly thereafter. I can't remember what it was called, but it wasn't a rare disease. And it really affected the ability of a lot of things to get going. When this committee was created, it had a mandatory 2-term limit, 6 years, which is sunsetting now.
Yes.
And unfortunately, this committee is really energetic. It's a really great group of people, and it would be a shame to see it break up because of a mandatory statute. But it sunsets in May, right?
Well, we began in September.
So it'll be September. Yeah. So what we would like to do, right, is to see if we can expand that to a 3-term maximum instead of a 2. And any advice that you can give me to help make that happen would be wonderful.
This sunsets this May.
September.
September. Yes, it was 2019.
It would have been helpful to have a bill last November.
I know. We just realized this like a couple.
Well, there is one other committee that Dr. Woods and I know about that, let's just put it this way, since you're all volunteers, there's nothing to prevent you from keep doing things
Right.
while the paperwork catches up.
Exactly.
But let's get the paperwork going, shall we? Yes, Representative Weber.
Actually, you've clarified my question, which was, because of the use of terms, I was having an issue of whether we were talking about people on the commission who had to go off the commission after 6 years despite having lots of expertise versus the commission itself going away after 3 years, which is what I think we're talking about.
Individuals.
Okay, now I'm really confused because first of all, about the commission. The commission is authorized through when? Or do we know? It doesn't have an end date.
There's no.
So the commission is fine. So we don't have to get Senator Rosenwald to reauthorize the commission in House Bill 2, which is what I was thinking about. So it's really just the terms of the people on the commission that are the issue. Okay, and I will duly note that in the minutes because I was quite confused about that.
Individuals may serve for 6 years. The commission doesn't sunset in its entirety in 6 years.
Correct.
Yeah.
Oh,
I'm
Okay.
sorry if I misled you, which I'm good at.
that notwithstanding, I'm glad you're not going away. So if an individual sunsets after 6 years, presumably nominations are in order for replacement people, and how does that take place here?
Right. So all of these individuals are appointed either by the governor or through the New Hampshire Hospital Association and the New Hampshire Medical Society. So I was appointed through the New Hampshire Hospital Association, and we can serve two 3-year terms, and that's the cycle. However, this is a public meeting, which is publicized, and anyone may attend, and we do have a lot of people who attend who have rare disorders or advocates for those individuals, and do so. I think what Representative Nagel is bringing up is that there are a handful of us rotating off, and we would not be voting members, okay? But we still can attend. And I think what he's wondering is, can we extend it instead of to 2 3-year terms, 3 3-year terms for individual members, so that we're able to vote? Because in the beginning, as he was saying, we hit the pandemic. There was a lot of stuff we couldn't do. We just feel like within the past year or two, we've really gelled and kind of come together and are able to do 2 or 3 projects a year, which is what we want to do.
Has anyone whose appointment came through the Hospital Association contacted Mr. Steve Annan?
I have not.
Yes, sir.
Senator Avard, I believe, is still on this committee. He is also a member of Senate Health and Human Services. And if you contact him, the Senate rules on putting in a non-germane amendment are much easier than
Yes.
the House's rules
Yes.
for putting in a non-germane amendment. And if that amendment is drafted and issued at the same time as a bill that you might want to put it on, and it doesn't have to be germane,
Right.
okay, that can be accomplished.
Let me write this down first. There. You good? Yeah, good. We're going to do this? Yeah?
Is that a good idea?
Today, before you leave? Good,
Yeah, that's
thank
a
you.
great idea. I'm gonna leave.
Hey.
I don't know, and I'm a doctor. I don't know anything.
Hey, I'm married to a doctor.
No, I'm
No,
not.
you are totally smart.
No, I just don't understand.
And now Representative McDonald.
Representative Weber, did you want to go ahead? Or-
Well, I was just going to say that it's particularly good timing now that we understand what we're dealing with, because the House bills are just getting heard by the Senate. And so, as Senator Gray says, if somebody goes with an actual amendment that can be publicized in whatever way the Senate does that, that could be really helpful. But that means that the contact needs to happen next week.
Can do that.
Just to get that done. Just for a time frame for everybody.
Follow up, if I may.
Follow up, Senator.
Representative Nagel knows the process. He knows Senator Avard
You're giving me way too much credit, but keep going.
and is well qualified to go talk to Senator Avard and suggest the language that can be brought to OLS.
Thank you.
And now Representative McDonald.
Thank you, Mr. Chairman. As popular as, at least in some quarters, as the whole concept of term limits is, wouldn't it be just much easier, given the difficulty finding people to serve on different boards and commissions, to just eliminate the restriction and leave it open-ended? And if you want to do 3 terms or 5 terms or not have a restriction on that, maybe that's something that should be considered.
Senator Rosenwald.
Thank you. I think I was appointed by the Senate President. I'm sure I wasn't appointed by the Hospital Association.
No, we were
Right.
appointed by
Or
our
the
legislative
governor.
body.
Yeah,
Right.
I'm sorry.
I'm sure that Dr. Nagel was appointed by the,
The chair is asking
If I can clarify.
Attorney Williams, if he's not already doing it, to check RSA 126A, CH 24-1, to find out who makes appointments?
Can I follow up?
Yeah, go ahead.
It's on my laptop right back there, but
You
the
may look at his
legislators are
laptop.
appointed, the legislators are appointed differently
Different.
Right.
than these folks
Yeah,
are.
I misspoke on that.
We are
Okay.
just
Yeah.
We're
appointed
getting
for
there.
2-year
We're getting it.
cycle.
Yeah.
They are
Okay.
appointed for 3-year terms. We're not as important as they are. And I do want to emphasize, if I could, that teamwork is really important getting things done. And when you suddenly have, I don't know how many people cycle out, but it's only 5.
Yeah.
5 people will be cycling out at one time. That is not a good thing. It's not a good thing. And I like what Representative, I'm sorry, I was going to call you Chairman, Representative McDonald said. That's,
He's also chairman.
I know, but not of this one.
Well,
You are. But I think that what you said would be, if we can do that, that would be,
that'd be nice.
I think that would be good, right?
Yes, no, we could just make it
Then you can be chair
unlimited.
for life.
No.
Representative McDonald.
And I say that for a number of reasons, but one of them is I know that the Speaker and I suspect the Senate President and others are always looking for people to be on various commissions. And in this case, we have good people already there. To lose them just because of a technicality in statute would be very unfortunate, I think. And in my opinion, good people should be able to stay as long as they're doing a good job, and that's certainly the case here.
For my interest, I see that Representative Francis Nutter Upham is no longer on the commission because, for one reason, she's no longer in the House, much to a lot of our regret. Who replaced her?
I can't pronounce her name.
Oh, it's Tapia Boris.
Yeah. Estafia Boris, Representative Estafia Boris.
Okay, thank you.
She's sweet too.
Now Representative Woods.
Thank you, Mr. Chair. Having been a member of that commission in the early days, then well, it was off. I'm happy to help out on the House side as well. So I sort of have a vested interest, shall we say.
Yes.
So I'm happy to help.
Any further questions? Any further statements? Let's see, Representative Nagel.
Is that all right about if I ask about the ALS thing?
You're not really supposed to.
Is that all right? Huh?
Offline.
What's that?
Offline.
Should we just wait?
Yeah.
All right. Can I make one comment though?
You may.
Never let a good opportunity to go to waste, but I've been in here for 2 years and 5 months now since I got elected. The best work that I think we do is in these committees where we work with subject matter experts. And I've been honored to work with so many wonderful people, like the two people sitting next to me, but also many wonderful members of HHS who I would be nowhere without in terms of learning a lot of stuff. So I just want to thank all of them for being part of my life and what we all do here. Thank you.
Good, thank you.
And I wanted to thank Senator Rosenwald for your service on our council as well as Representative Woods, who have both rotated off.
And Representative Weber.
And as long as we're doing thank yous, in my family, we had a death of a young adult, which was attributed to a relapse after addiction. And genetic testing revealed that that young adult had that syndrome that sometimes makes very, very healthy young males just expire. And I cannot tell you the benefit for his parents in terms of their own internal angst. It will never remove the pain of losing him, but it has taken away the guilt of what did we not see and what did we not do, and did he make an unfortunate decision, and it just wasn't preventable. So I can't tell you how much I want to thank you from my heart for doing that genetic testing.
Thank you. Thank you for sharing that. I totally agree. It's life-changing for these parents, life-changing. And I'm just so happy that we're able to do that now with every child who dies unexpectedly.
Representative McDonald.
Thank you, Mr. Chairman. Getting to the Young Committee, the sudden death in the Young Committee, I noticed you single out drownings in children older than 5 and drivers in motor vehicle accidents. I assume there's some data that caused you to select that particular category, and I was wondering if you could share that with us. Or otherwise, provide us the reason why you set that up that way.
Right. I think, and I'll defer a little bit of this to Courtney, but my understanding is in that drivers in motor vehicle accidents that are my understanding is unexplained, right? So all of a sudden the driver just goes off the road, hits a tree and dies, a young kid. If there's no alcohol or substances, found no real reason for that. The thought is that child or individual, young adolescent, may have a genetic condition that could have caused that, right? An arrhythmia, all of a sudden they go off. So that's my understanding for the driver of the motor vehicle accident. And then drownings, it was always thought, if there's nothing that the medical examiner finds to indicate that the drowning is due to substances or like you hit your head, you go into the river, something like that, is that these individuals, it's more based on individuals who you would not think should drown. So individuals who can swim, that type of thing, that they actually drown for no reason. And I don't know if you can add that. And a lot of this, the stipulations here are coming from the CDC because this is a grant from the CDC, Centers for Disease Control, in affiliation with the NIH and the University of Michigan Biorepository, began these sudden death in the young committees, and so there's very specific stipulations of which individuals will go through the process of being evaluated.
Okay, thank you.
Okay.
Thank you so much for coming.
Can I just bring one more thing up? Again, never let a good opportunity to go to waste times too. And this is related a little bit what you just said, what you asked earlier. Dr. Woods and I both knew Dr. Seatbelt, the gentleman that created the functional seatbelt.
Here's my office.
I did look through the accident report that is required. I did not see seatbelt on that anywhere. And maybe that's something for you and I to do because that's important information, important data. Maybe we can work together and get that done. Yeah.
Good. We're now going to take a look at today I found out that the people who are going to be with us, wanted to be with us, are with Division 3 of House Finance. And this goes back to Senator Gray's request for periodic quarterly budget updates, et cetera. And I suggested that we still do a presentation here. I had asked for somebody from DHHS, and I see at least two somebodies from DHHS, to be here to listen to what Senator Gray wants to say as an initial presentation, sir.
Okay, at the last meeting, there was a question of whether or not our charter includes, looking at financial things. And so I know that you provided 15, I provided 126-A13, 14, and 15, which are the three that do there. And certainly, I've highlighted that we intentionally put a member of finance from both the House and the Senate on this committee. And if you go down to Roman 3 at the bottom, you see to support cost effective in there. And if you look then at 15, which you supplied, efficient is another word in there. Mm-hmm. Now, what brought this to mind is that I got the report that we were $47 million short on the lapse, that the departments who, were assigned lapses, that money was not all going to come in. And I says, well, who should be looking at that? Who should be looking at, should it be fiscal? Should it be whatever? And then I went into this statute and I said, well, seems like there should be some kind of look at cost effectiveness, at how they're doing, and that kind of thing. What do I want for a report? I don't know. Okay, but I do know that periodically I'd like to know how they're doing on their laps, because their laps right now, if it comes in where I think it's going to come in, they're going to be about $11 million short on their laps. And because of the number I was given, 47 million, that's 22, 23, 24% of that lapse, which is a significant amount of money that we're not going to have by the end of the year. So you've got cost effectiveness, you've got efficiency, you've got all that other stuff that we're supposed to be looking at. How are we doing it? So that's a question for the committee, but certainly the department, and Mr. Williams knows that I've talked to everybody. I've talked to the finance guy, I've talked to the commissioner, and I've talked to Mr. Williams, that I'm willing to have them come and make a first cut at this at our next meeting, about what they think is appropriate, and then we can continue this conversation after that presentation.
I am chairman of the board of a medical counseling and massage facility in Kingston, and I don't wait until 6 weeks before our annual board meeting for a breakout of things. We get it quarterly. It's very helpful. If the train's starting to go off the rails, I want to know it sooner rather than later. So whatever we need to be the oversight, I would underscore we need to see these things more and more frequently. Representative Weber.
And as one who perhaps misunderstood the direction that Senator Gray was going in last time and was kind of horrified at the idea that we might be reviewing the entire DHS budget in this committee, which seemed to me to be a lot. I want to say that certainly with respect to the lapse, having reports either every 2 months or quarterly or something like that, I think is very prudent and not intrusive at all. And certainly looking at other things that we ought to be looking at is a great start. But I think definitely as to the lapse, perhaps we could just say we want to look at those going forward.
Representative Woods.
Yes, I would completely concur, and especially as we found today, there are some contingencies that arise to the tune of $80 million in today's particular instance that we might want to be aware of and anticipate. So it's besides the lapse, it's other unknowns.
Children and Family Law Committee has retained a bill from a House member wanting regular updates from DCYF. And we could certainly ask quarterly, I think, how many caseworkers do you have? And how does this number compare to the last quarter? What is the expenditures in supervisory personnel as opposed to actual clinicians? These are kinds of things that are very important. I know there has been an attempt, there was an attempt last year to do a deep dive into DCYF. I think that periodic look-ats might be helpful to spot trends and not therefore have the need for the kind of intensive look at that this committee was going to do. So that's, again, just my 2 cents worth before they demonetize. Senator Rosenwald.
Mr. Chairman, I share Senator Gray's frustration, particularly over the lapses.
Yeah.
We get in the fiscal committee a monthly dashboard from DHS, which does actually tell you how many caseworkers they have in DCYF, how many are actually in service, how many are out on leave, all sorts of great stuff about the caseworkers. But the first page of that dashboard is for their financials. Most months, the department does not complete that information. And occasionally, we have been given a lapse number that we all know is not realistic. Like, remember when it was 5 million? So I think maybe because we're requesting the executive branch to give us information that they don't necessarily feel the need to share with us all the time. I'm wondering if we might consider legislation requiring. And I wouldn't wait. I would start getting information on the lapse 6 months into a budget, because it takes a long time to turn the Queen Mary around. I mean, you know, a hiring freeze that was announced in January is too late, really. We should have been getting better information from the department for a year before that. And so I think just asking for lapse numbers might not compel the executive branch to share that with us unless we compel them.
By way of a parallel, for 2 years I chaired the commission special committee on the family division of circuit court. And many of the things we were talking about as a special committee, the judiciary with whom we had built a very cordial relationship started doing them. And I kid Representative Alicia Gregg that she is our secret weapon, because all she would have to do is say, you know, that would be a good thing for them to have. And 2 months later, they came and told us they were already doing it. And I think, personally speaking, maybe someone else has a different relationship with DHHS. We have a cordial relationship. And as they understand the things that we would find helpful, I'd love to see this done so that legislation is not necessary. That could make it a bit adversarial. It could be necessary. But I'd like to start, as we work on the presentation next month from both sides, how we can have a similar experience to my salutary one with the judiciary. Senator Gray.
Don't get hung up on lapse only.
Yes, sir.
Okay?
Agreed.
Mr. Williams, we can relate a story about the bill that was talked about before with the water division. And they brought me over a bill, and I sent them back twice. All right? And they originally came and said, well, instead of giving half of the money that we get from fees to the budget, or to unrestricted funds, that we want to retain it all. And by the end, we had them found another piece of equipment that they could use. We found different things. And so these discussions about efficiency at either the department level or reports up here are the kind of things that need to go on. And that's the same thing when we talk about the audits that I talked about in the last one. They're doing audits. Do you know what audits they did? You're the Oversight Committee. Do you know anything of the findings that they found? I don't see any hands going up. Okay, what audits do they do?
I'm on the audit.
But again, so when you look at our duties, okay, that these both fall well within what our duties are, and we need to say, well, I don't want to go hog wild. I don't want them to come in here with a line item budget and say, oh yeah, we spent an extra $5 here. You know, I want to look at the process and how, you know, like a report from the audit committee every 3 months that says, yeah, we did this one, this one, this one. There were 17 findings, and the oldest finding is, you know, 3 years old. And then we can go ask, why is that one 3 years old? So again, I'm not trying to reinvent the wheel, but I am trying to say that if I don't know the answer to some of these questions, I don't feel I'm doing my job as someone who's providing oversight.
Representative Weber.
just for the minutes and so I'm understanding, are we speaking about the audits that are done under the auspices of the Legislative Performance Audit Oversight Committee, or are we talking about internal DHHS audits about which I know nothing? Is it the internal DHHS audits?
Department of Health and Human Services audits.
Yeah, okay, thank you.
That comes from the requirement that their organization was actually there before, but I asked, how do you know that you're actually doing
Right.
the things that are in the statute? And I was told they have a committee that does that.
Okay.
Along with other things, I think, that takes care of that. So
Thank you for the clarification. That's what I needed.
Before I forget, this conversation started at 2:40, so if you want to go back and review this discussion, that's when you can tune in. Not that the other stuff wasn't great, but this started at 2:40. Representative McDonald.
Thank you, Mr. Chairman. As many of you know, I was in the department for 23 years. Poor Mr. Williams had to put up with me throughout that period. He's never been the same since, I don't think. But with some bias, I have to say they do a great job with the resources they have. It sounds like they have a lot of money. They do. They have a lot of responsibilities too. I very much appreciated the commissioner's update today and her explanation of what that $80 million is going to mean, especially where the federal government unfairly did it 15 months ahead of time. I think the more insight we have into the financial operations of the department, the better. Yes, for our mission here, but also for the benefit of the department. So we can not only be I don't know what term you want to use, an overseer of the department, but also perhaps even at times an advocate of the department. Just one example, in HHS, Health and Human Services and Elderly Affairs, there was a bill, for example, to eliminate the Office of Health Equity. That had potential significant financial ramifications. And we ended up retaining it, one of only 2 bills we did retain because we weren't sure of the fallout. And the sponsor and many of those who would have otherwise supported it weren't aware of the financial implications if we had in fact passed it. And there are other bills like that also that I'm sure that get introduced and may get introduced. So the more information we have, the more beneficial I think this will be for all concerned, to include the department.
Thank you. I was waiting. We had 4 seconds. All in favor?
Aye.
We are adjourned.
So is this